So what we tried to do is to thread our content throughout the curriculum. Within the first quarter, we introduced the students to our diverse faculty. We have individuals who are specialized in orthopedics, but also pelvic health and everything in between. We give an introduction as to what exists, how we got there, and what resources there are for the students.
Hi, I am Nick Rainey. I am part of AOMP's Pelvic Health SIG and the SIG's former vice president. I'm also on the research committee with AOMP and an interviewer on the AOMP podcast through that committee. Today we have Natalie Turrentine, a board-certified orthopedic therapist at Rosalind Franklin University in North Chicago. Welcome, Natalie.
Hi, Nick. Thank you for having me today. I'm really looking forward to talking more.
Well, we're excited to have you on here. As I was thinking about what to do for this podcast, I was doing some research, and I came across your poster at CSM 2024. You and several other students presented a poster titled "Prevalence and Faculty Perception of Obstetrics Education at the Entry-Level Doctor of Physical Therapy Curriculum." When I came across this, I thought it pertinent for our listeners, as we've all been in entry-level programs. All of us care about the direction our profession takes, and some of us are involved in entry-level programs currently. As this is an orthopedic and manual therapy organization, normally the emphasis is in these areas. I personally love the immense crossover between pelvic health and orthopedics. Since I want more people to appreciate this, I thought this would be a pertinent poster and pertinent discussion for everybody.
Thank you. Yeah, I'm definitely in agreement.
So I wanted to start off with a bit of a broader question. In your research, you use the term obstetric rather than the more common physical therapy term pelvic health. Can you elaborate on the distinction you see between these terms and why you choose to use obstetric in this particular study?
Yep, sure, of course. So as you already mentioned, I come from a lens of I'm a board certified orthopedic physical therapist, and I'm also an academic. So when I started working on my line of research, I really found that I wanted to find a category of interest based off of what I had already seen clinically. So the settings that I had worked in clinically were primarily outpatient orthopedic. And I started to notice a trend that if someone were to call with any type of pathology or any type of diagnosis and also happened to be pregnant, that they would automatically be referred to a pelvic health specialist, which in many cases that may be best case scenario. But in other cases where perhaps accessibility is limited, there may be a little bit of a disconnect between what I was seeing clinically and what I thought maybe could be happening. So this is really the premise of why I wanted to start learning more and looking a little bit into the term obstetrics, as mentioned, and our current practice of obstetrics. So what this led to is one of my first research studies with a student group was looking at the opinions of outpatient physical therapists. So we surveyed about 600, a little over 600 outpatient physical therapists to get their perspective on what was currently happening in the field. So we had a pretty good mix of pelvic health specialists, orthopedic specialists, and individuals who identified of not having any specialty at all. And we asked questions about if someone were to have a diagnosis of, let's say, shoulder pain or back pain or knee pain, what would you think? What do you think would be the best person to see this particular individual? And overwhelmingly, with the exception of wrist, hand, and then diagnoses that pertain to the foot, these physical therapists said that a pelvic health specialist would be most appropriate, which again, that may be the case, but we do know that accessibility can be limited. So we wanted to see what can we do to fill in a gap where needed. I feel like as a profession, the more generalized knowledge we have, the better off we can be in our ability to not only diagnose and treat, but also refer. And I do feel like sometimes there's a stigma or an apprehension or maybe a fear of treating individuals who are pregnant and postpartum. And so my goal in my line of research and teaching and advocacy is to make sure that's not the case. You know, if someone comes in and they are pregnant or they wanted to return to something postpartum, that as a generalized physical therapist, we either know what to do or we know when to refer. And so that's why I use the term obstetrics.
That's great insight. I know when I first looked at the study, I didn't think about it just from a pregnancy lens, and when I first looked at the title there,
Sure.
that what you're saying is that when people would come in and they were pregnant, automatically pass to the pelvic health therapist, no matter if it's even if it's not lumbopelvic or specifically pregnancy related.
Correct. Yeah, and that was my observation, and I think it could be at least a little bit generalized to more of what's going on in our field, just based on the research that I've done thus far.
That also makes me think of like a pediatric specialist. A lot of times we talk about pediatrics and not little adults, but we're kind of treating the obstetric patient like that. The
Right.
pregnant patient that we're going to be sent to the pelvic health therapist because it must be different, even if it's a shoulder issue or whatnot. Whereas with pregnancy, I can definitely feel like there's some specific considerations for lumbopelvic hip, but maybe not for shoulder, knee, and obviously they didn't, with the respondents for hand, wrist, ankle, foot, it sounds like.
Yeah, absolutely. And not to downplay by any means. There's definitely a time and a place where a pelvic health specialist, they are most equipped, right? But I do feel like if we reduce some of the stigma and the fear, as we said, that we could reach out to a bigger population. You know, our research continues to change and to advocate for more activity and more exercise and the ability to return or keep up with certain athletics. And I feel like that's something at entry level we could at least have some exposure to so that we could have education for our patients.
That's great thoughts. So I guess a little more follow on the entry level.
Sure.
For those of our listeners who may not be as familiar, could you briefly explain the CAPTE requirements regarding pelvic health education in general, maybe obstetrics more specifically,
Mhm.
in physical therapy programs?
Sure. So for CAPTE requirements, they are broken up into these things called elements. So there are a list of different elements that universities or institutions need to show evidence that they're doing. So, for example, one of the elements that we have in academics is an element that makes sure that we address the anatomy, physiology, pathology, throughout the lifespan, including different categories. So, including genital, reproductive, gastrointestinal, and the list goes on. Once we evaluate that element, then we have to show what objectives in teaching and how we really teach this information. So I use that as an example because usually these elements, they give you some leeway in how you're doing them, in that each institution can be addressing, for example, this one particular element cited a lot of different ways, right? So not only do we have these CAPTE standards that we have to show evidence of, but we also have these other influencing factors within academics. So we use the research coming out of the APTA, we use the guide to physical therapy practice, we use ACAPTE information, and then also the MPTE. The role that I'm in here at the university is helping in student support for the board exams. So we also have to have an awareness of what is and is not being tested. So there is a category under the MPT, the FSPPT, that does talk about pelvic health. So we do have these certain standards that we have to meet, but outside of that, there is some ambiguity as to how much and in what detail this information has to be included in our curriculum. The APTA has a guideline for curriculum. That guideline is a recommendation. It is not something that is published by CAPTE. So it is a really good resource for anyone in academics who are looking for a guideline. But the CAPTE recommendation itself is a little bit broad. And I think that that's important to bring up in some of the next questions too.
Wow, that was a very detailed answer. You were the right person to ask that question too.
Thank you. We just went through our reaccreditation, so I have learned
Okay.
more about that than I ever would have known otherwise.
Well, very good. Good timing then. Uh, as you said, it could be vague, or a little bit broad, what the requirements are. And with your detailed knowledge of that and your interest there, I'm assuming that you've worked to do this at Rosalind Franklin University. Could you share some specific ways that you've successfully integrated pelvic health and obstetric education into your curriculum there?
Yeah, of course. I'm really proud of the work that's been done here, and it's something that we've put some thought into. So, what we tried to do is to thread our content throughout the curriculum. So, what we mean by that is within the first quarter, we introduce the students to our diverse faculty. We have individuals who are specialized in orthopedics, but also pelvic health and everything in between. So, we give an introduction as to what exists, how we got there and what resources there are for the students even in starting in their academic career. So really to kind of give a gauge as to these are all of the things that you'll be able to do after your entry level academics. Then later in the curriculum, we get a little bit more specific. So we incorporate some of the obstetric considerations. Um, I have a class session where we talk about just broad understanding of all the physiological changes that occur and how we have to adapt our examination if, for example, we were seeing someone for their ankle and they were in their third trimester. So starting to problem solve, how will the person feel most comfortable and safe, in our evaluation technique. Another thing that I'm proud of is that we've had the ability to bring some of the continuing ed courses to our campus. And I really think that this has helped with accessibility for our students and community with some of the pelvic health and obstetric coursework that exists. So I think it's
Very
going
cool.
well. Yeah.
Yeah, I think that, I mean, if an orthopedic therapist is seeing somebody for their ankle, to not have any idea how to, the considerations for a pregnant patient, I think is, very important there. So I think that's great. You're able to incorporate that. And that's maybe unique, somewhat to your program. I can't imagine that's ubiquitous across programs there. So that's excellent.
Yeah, thank you. I appreciate it. We're trying.
And with the continuing education courses, do clinicians from around the community come to those? Is it just focused
Yeah.
on your students, or how do those work?
No, so we've hosted the APTA sanctioned courses, so Pelvic Health 1, and there's an obstetric certificate where there's a lab portion. So we've hosted the labs on campus, and they're open to anyone. And the hope is that in bringing them locally, that we could also have some of our students enroll, which they have, which is wonderful. Some of our new grads have enrolled, but then also anyone. I'm in the Midwest, so we've had a lot of people come from the Midwest, but really from anywhere. It's open to anyone.
I think that's fabulous. As a clinician, one of our recent grads that we brought on, she'd already had some specific pelvic health training she'd done in an extra coursework before graduating, and that really sets her off for the ground running
Oh,
when she
absolutely,
started practice. So that's outstanding.
absolutely. Thank you.
I also really liked how you talked about the faculty talk about how they got to where they're at.
Mhm.
I think that's really important for students to have a vision. We all know that we models are extremely important in life, and so they could see where other faculty have been, and you get that early on. It sounds like in your program. I think that's very excellent. So kudos to you on that as well.
Yeah, thank you very much. We've all gotten through different ways and different pathways to get to where we are now. So I think everyone on our faculty just likes sharing that and showing that there's not always a direct path, but there's different options depending on what piques your interest. So we want to make sure that we expose our students to that.
So as it going on with entry level education, then, uh, so you've been able to really focus on that at Rosalind Franklin University. What do you see as the primary challenges that other programs may face in implementing robust pelvic health education, and maybe any ideas on how these challenges can be addressed?
Undoubtedly, I would say time. This is a question that we specifically asked in our survey, and overwhelmingly, that's what the feedback was time in the curriculum. Um, I could say firsthand, I'm a part of the curriculum committee. As I mentioned, we had just gone through reaccreditation, and we have a lot of good stuff. Within our field, we are a pretty generalized profession in that when those students take the board exams, they have a lot of information about a lot of interesting things. So, because of that, time is always of an essence, and you need time in order to either add content or make sure that you're doing things to the standard in education that you want to achieve. Um, so that being said, I've put some thought into how we can do this all, right? How we can still have generalized information without adding on to time. And I guess my thought is, and this just may be my perspective, but I feel like we already do a lot of things in which this content could be incorporated. So, a couple examples. So, we start off, at least in our curriculum, we have some generalized sciences, we have anatomy and physiology. And from my perspective, I feel like if we had a conversation about, for example, the physiologic changes that occur in pregnancy, we don't have to go into too much depth, but at least have a touch point early in the curriculum. Then we could build on that later in our clinical sciences. We could maybe supplement some of the cases that we discuss and use a case in which someone's in their second trimester. They're 1 month after they're having a baby and they want to get back into running, or 1 month and they have a certain occupation. We could use this case information in things that we already do in order that for us to have repetition and improve the comfort level of our students in working with these individuals.
As I think about, I'm a clinical instructor, and for most months out of the year, we have students here at this clinic, and I'm continually, I don't know about surprised, but how much that things they do remember from their entry level education. I'm just like there was this one slide, 2 or 3 semesters ago. There's one little discussion that they log away, and then when it becomes pertinent, they can bring it out. And so,
Mhm.
I think that approach as you're discussing, even just being here in our clinic, if our students have some of those, a slide here, a conversation there, it would benefit them at those moments when it's needed. It's not going to, it may not be every day for a lot of clinicians, but when it's needed, that's how a lot of our education is, that we don't use it
Yeah.
until the one day that it's needed.
Right. The one day where it's really important, right? And at least you could look back at a discussion that you had, right? That otherwise maybe you wouldn't. And so stuff like that, yeah, it does take some time, but we're already doing a lot of things where this information could be incorporated. And I think it would be for the better good for those couple of people that really need it.
Do you have any examples to illustrate the importance of this topic? Maybe where there was a lack of obstetric or pelvic health education and it negatively impacted patient care.
Sure. So I'm sure there are some specific examples, but I think something that really sticks out to me is some of the responses that we got in our research. So, an example in one of the studies that I had talked about, we had over 600 physical therapists respond. So it's a pretty good amount. And in that research study, about 87% of them, so that's 530-ish, physical therapists reported that patients they did not receive enough information about their physical well-being during their pregnancy. And that number went up when we asked about patient education after their pregnancy. It was about 96% of our physical therapists, so people within our profession, said that individuals did not receive enough education. And so, those numbers, those stand out to me in that there's something that we could do, right? If a big chunk of the PTs that were at least answered the survey are saying that they don't think that patients are getting the education that they need. We know that information is really crucial for wellness and well-being and even seeking out medical attention. So I feel like having the knowledge that there's something missing is enough for me to say we should do better, right? And I think that was a primary base for why I wanted to start looking at what is happening even nationally at the entry level, and why I wanted to start having this conversation here, and just trying to advocate for change, or trying to advocate for the ability to incorporate this information so that we could better serve our patients.
Well, I think that was a great answer as well. So, outside, it's difficult to have maybe a specific example where, because we're going to be able to provide some level of care, but
Mhm.
if the patient and the provider side both feel that there's information lacking, that means the patient is wanting it. The provider, the physical therapist knows that they would like to be able to provide more,
Mhm.
but they don't have it themselves. So that's a great answer on how if we can have a little bit more to give them, then both sides are going to be appreciative there.
Yeah, that's the hope.
Uh, any other thoughts that you have? Anything you'd like to share with our audience before we finish today?
That's a loaded question. Um, no, I
The
think
floor is yours.
no, I'm proud of what we've achieved so far. I'm proud of the changes that we've made at our institution. And I just hope that, we continue to see progress. I think that we will. I'm optimistic. We have certificates where they never existed before. I'm continuously reading of new research and protocols where they never were there before. But I think that as long as we continue conversations like this one we're having today, that we're on a good trajectory. There's just more work to do.
Cool. Well, thank you very much, Natalie. I appreciate you coming on today.
Yeah, thank you. It's been nice talking with you. I appreciate it.